Ladies and gentlemen, in this lecture I will present all practical aspects of inducing hypothermia into a newborn as a therapeutic measure. In the first part I will describe how you assess the newborn so that you know which newborn you will subject to hypothermia, which you will treat with hypothermia. In the second part, I will then discuss how to treat it, and we will have a third session on the technical aspects of hypothermia. Next slide. First, I want to present how you diagnose, and more important, how you assess the severity of hypoxic ischemic encephalopathy, because the diagnosis that a baby is asphyxiated is not very difficult. However, the accurate assessment of the degree of severity is more difficult and is more important, so that you know which baby to treat and also to relate the effect to the initial severity. Next. First, we learn that when you delay cooling, the effect of cooling will be less and less. In this graph from Alistair Gunn, using animals, he clearly showed when you treat these animals very early, 1.5 hours after the injury, you can reduce the number of cells which are dead and lost from about 90 to about 30%. Quite a strong effect if you start cooling 1.5 hours after injury. When you start at 5.5 hours, you can rescue only about half of the cells. And when you start at 8.5 hours, there is factually no difference to the control group. So the message is very clear. The earlier you start, the better it seems in terms of having a stronger effect. A study done at Johns Hopkins Hospital on newborn piglets, where they made cardiac arrest to the newborn piglets and started immediately after their resuscitation with hypothermia, there was factually no injury in the brain discernible on histological grounds. So the discussion will always go towards earlier cooling, maybe even immediately after the delivery, starting hypothermia in the delivery room. Next. Now there will be a part which tells you how to assess and monitor the babies which are born asphyxiated. Immediately after delivery, you will assess, as you know, APGAR 1, 5 and 10 minutes values, base deficit, pH and PCO2, which is also important. Then I propose that you assess the duration, how long the heart rate was less than 70 before or after delivery, as a measure of the decreased cardiac output. You would assess the duration for how long the pulse oximeter was below 50% saturation after delivery, and how long you needed ventilatory support. This, however, implies that you check whether the baby is breathing spontaneously or not, and give it a try. The same goes for the onset of spontaneous breathing. So this would be always giving a certain time the baby had heart rate below 70, saturation below 50, how long it needed ventilatory support, or how long it took to start breathing. It's also advisable to measure rectal temperature 10 minutes after delivery, because I told you already, the brain is the main source of heat for the body. If the brain is ruined, if it does not have a high metabolic rate, there will be no metabolic heat brought to the body, and the rectal temperature, the body temperature, will fall. In the first 6 hours after delivery, you should assess the neurology, the seizures, the frequency, the duration, which medication you had given particularly in respect to phenobarb and diazepams and others, you would assess the neurological signs best by using the Thompson score and, as I said, again, measure rectal temperature. Next. The definition of hypoxic ischemic encephalopathy has 3 prerequisites. First, you must have an intrapartum distress. There must be some signs of intrapartum distress in form of an abnormal cardiotochogram and maybe other things like assessing scalp pH. Then there must be neonatal distress, as we just described. This alone does not yet make hypoxic ischemic encephalopathy. This makes just asphyxia or postnatal depression. A third criteria is that you find neurological symptoms which indicate that the brain has been injured, and that makes the diagnosis hypoxic ischemic encephalopathy. So please always discern those points. Next. Now, obstetrical evidence of intrapartum distress are, as I said, cardiotochogram signs, depressed scalp pH. Fresh meconium is a very weak sign, but it may count. Obstetrical causes must be present: prolapse of the umbilical cord, cord around the neck, placental abruption or rupture of the uterus, and others. Because you must have some indication something is happening perinatally. Otherwise, the damage could have been weeks or months before. Next. So, we then have already said neonatal distress would be indicated if the APGAR score at 5 or 10 minutes is less than, for example, 5. Delayed onset of spontaneous respiration. Long need for ventilatory support for postnatal respiratory support. Depressed pH in the umbilical cord, and what you can do is to use the blood gases you draw within the first hour after delivery. Interesting enough, they are very similar. When you take blood gases immediately after delivery and again about 1 hour after the baby has been born, they are often very, very close. And then, of course, increased base deficit indicating lactate. Next. Then, please do not forget, asphyxia does not only affect the brain, it also affects the liver. That's why you look at deranged liver function. It affects the kidney. That's why you look at renal impairment, particularly oliguria, rising creatinine. It also affects the myocard. You look at cardiac function and coagulation disorders. In particular, very important to evaluate whether there is disseminated intravascular coagulation. Next. Now, for cerebral dysfunction, you would assess the abnormal muscular tone, the abnormal level of consciousness, which is difficult, I agree, and abnormal posture, which is very indicative, but also abnormal reflexes such as sucking, Moro, and others I will tell you. And of course, whether seizures occur or not, and several other neurological items. Next. For many decades, people have used the score from Sanat and Sanat, published 1976, which yields 3 stages, but needs 14 items to assess. And in particular, it needs actually 2 days of observation to make the real judgment of the severity. I propose, and we have used, the Thompson score, which was published by Claire Thompson from Cape Town in Archives Diseases 1997. The Thompson score has only 9 items to assess, but yields a very large scale with 22 points. So this is a much better and finer gradient measure you can use. and it takes only 9 items to assess, and it is actually useful already from the beginning onwards, because the Thompson score is just an evaluation of all neurological signs you can have with hypoxic ischemic encephalopathy. Next. Here is the famous Thompson score with these 9 items, like the tone, which can be normal, hypertonic, hypotonic, or completely flaccid. Then the level of consciousness, as I say, is difficult to assess. You all know those babies who are staring, who are looking alert, or who are very lethargic or even comatose. That means even pain stimulus does not cause any reaction. Seizures are classified as infrequent, less than 3 on the first day, and then more than 2 per day. Very important, the posture, the fisting is a very well-known sign, the so-called cerebral thumb, the fisting, and of course all monotonous movements, cycling. Then very strong distal flexion and the decerebrate position, which is the worst, indicating. Then we can do 3 reflexes: Moro reflex, grasp reflex, and suck reflex. You can do that even in a baby which is intubated and in intensive care. And they are classified as normal, partial or poor, or absent. Respiratory-wise, you would see whether the baby is hyperventilating, which is often the case. They ventilate such that the PCO2 may even fall to levels as low as 11 or 12 millimeters mercury. And then if they need support because they have always apneas or they are completely apneic. The fontanelle should also be assessed. The total score is 22 points, and so this is a very fine scale, and it's very clear every baby should be assessed in the first hour after delivery, at 6 hours, at 12, at 24, and then at least once a day, because it tells you very exactly how the baby recovers or deteriorates. Next. Then you would plot the score in this graph, which shows those babies here with a Thompson score higher than 7 being at risk of having abnormal neurological outcome at 1 year of age. You can see that the deterioration of the score on day 3 and 4, according to the secondary phase of asphyxia, as I told you in the first lecture, and you would plot the points, the score here. If the baby has less than 7 and comes down to nearly 1 or 0 in the first 10 days, the prognosis is very good. Next. We have analyzed the predictive power of various variables by the so-called receiver operating characteristics, which is not dependent on the cutoff level, and so sensitivity and specificity is not dependent what you choose as cutoff. And you can see, first of all, the Thompson score appears 5 times amongst the 6 best predictors. Thompson score at 6 hours, 12 hours, 7 days, 10 minutes, and 1 hour. Very high area under the receiver operating curve. Only the AEG or EG on day 7 is similar in predictive power. All other things like Apgar at 10, 5 minutes, pH, base deficit are also very good predictors, but not as good. The AEG at 48 hours is not very predictive. Ultrasound also not. So I think this is an important message. From now onwards, I would suggest that in all neonatal intensive care and other units of the Greek Empire, of the Greek state, I mean the empire under Alexander was a little bit larger, now it's not so large, all will have the doctors train the Thompson score and reliably assess it every day in an asphyxiated newborn, on the first day more often. Next slide. Here I show you the tracings of an amplitude integrated EEG, which is normal, which is moderately abnormal, and which is severely suppressed. First of all, you must learn that an EEG is assessed by looking at the voltage, at the lower voltage. I'm showing that here, the lower part of the voltage and the upper voltage. And this is only possible if you record at a certain speed. In this amplitude integrated EEG machines, it must be very compressed. Otherwise, it's difficult to draw the line of the background voltage either in the lower or in the upper range. A normal EEG is one where the upper voltage is higher than 10 microvolts and the lower voltage is higher than 5 microvolts. Very clear. A moderately abnormal EEG is one where the lower voltage is less than 5, the upper is still more than 10. A suppressed EEG is one where, and please, this is the EEG here, the dark band, where the upper and the lower voltage is less than 10 and less than 5 respectively. What you see here is burst suppression pattern, and this is not the line to draw here. You must draw the thick, compact amplitude recording. Next slide. I have shown you already that seizures can be detected in the EEG by elevating voltage, both upper and lower being elevated. And as I said, independent of the voltage background, seizures are always a sign of central nervous injury. Next. I have told you that the EEG is the so-called gold standard for predicting by electrophysiological means the outcome. Very high sensitivity, very high specificity. What I want to point out here is the following. Even if you have a normal EEG, there are some babies which will have impairment or even die. So that means it does not completely rule out that the baby is absolutely fine. On the other hand, you know that you have an abnormal EEG. Some of these babies will have no impairment. Not every baby which has an abnormal EEG per se has 100% impairment, but of course is a very high predictive power in both specificity and sensitivity. Next. I have told you that you would always have the EEG, the electrophysiological assessment, and the clinical assessment. They would have to go in parallel. And from this graph you can also learn that you must keep the EEG going, the assessment going, because asphyxia is a dynamic process, a first phase, a short period, therapeutic window, and the second phase. So it's very important to monitor for days and days. And the recent opinion amongst our colleagues is that depending on the course a baby takes during his first days will not only determine the prognosis and alter the prognosis, but in future also alter the therapy. A baby which does not improve at all might be given other drugs. Stronger efforts are made to get the baby better. While those who are doing well, one would withdraw therapy earlier or not add other things. Next. Now a patient example. A patient has, a patient has an uneventful prenatal history, perinatal, spontaneous vaginal delivery, the umbilical cord once around the neck, normal birth weight. Postnatally, the Apgar at 1, 5 and 10 minutes is only 1, 3 and 3. pH in the umbilical cord is 7.07, base deficit is 17 millimoles. So the diagnosis is very clear. This is perinatal asphyxia. If you want to give it a more gentle name, you would call it suppression for legal reasons. Next slide. The Thompson score of this baby shows that the tone was hypertonic. There were no seizures. You can see the doctor did not indicate the level of consciousness. He inferred it obviously then. The baby had the typical fisting and cycling. The motor reflex was absent. The grasp reflex was absent. The suck was poor. And the baby needed ventilation because of apnea. And the fontanelle was normal. That gives us a score of 10. And so it's clear this baby has a high risk of an abnormal outcome at 1 year and later, and therefore is qualified for treatment. Next. This is the corresponding AEG. You have already learned that the lower background voltage is below 5, and even the upper background voltage is less than 10. So this is a severely asphyxiated, suppressed AEG. Next. We also have, of course, before we cool, make sure that the baby meets inclusion criteria, because it's important, and all inclusion criteria are based on a certain stepwise accession. You would first have the diagnosis of asphyxia, then the additional neurological finding will make the diagnosis of encephalopathy, and you would have the AEG. And this then gives you the clear indication whether the baby is moderately or severely or not at all asphyxiated or having hypoxic ischemic encephalopathy. Next. You also would have exclusion criteria. For example, as we said already, cooling starting later than 5.5 or 6 hours, we made it 6 hours, has less and less effect. So that has to be considered. If you have given phenobarbital, that makes it very difficult to assess the severity, and you would also not treat babies which weigh less than 1,800 grams, purely because the smaller the baby, the more difficult it is to maintain a certain temperature. You will have always a strong overshoot to lower or to higher temperatures. You want to have a normal head circumference. That means to rule out diseases which were there before birth, and of course congenital malformations of severe, which per se have a bad prognosis. Imperforate anus is mentioned here, but actually is not the real exclusion criteria if you have esophageal temperature measurement. Axillary temperature is not good. And of course, any baby which is close to death, near death, in extremis, we would not treat. Next. Now, some practical advices how you manage the baby immediately after delivery. First, you would keep the CO2 levels rather at the higher level. That means rather 50 up to 60, definitely not below 40. Because it has been shown that higher CO2 levels are per se neuroprotective, maybe because of increasing brain perfusion. And you would keep glucose levels to normal, because glucose is also very important as a source of energy. And you would not give, or if necessary, low anticonvulsive drugs. You would, from now onwards, you probably do already, avoid all hypothermia. That means you would not switch on radiant heaters and all those things. You keep the body temperature at low normal. And finally, you would start hypothermia treatment if it's indicated, and if possible transfer to a specialized center, but start wherever the baby is born and provide hypothermia in any case. Next slide. This is just a study from Vanucci which shows when you mix in carbon dioxide into the circuit of an animal, then you have some brain protection. That means the right and left hemisphere, the one hemisphere being injured by ligating the carotid and having hypoxia, would not be less in brain mass than the other. That means this is a much better outcome than this. Anyway, CO2 at a higher level is protective. Too high again is not protective. Next slide. This slide shows that when you have hypoglycemia, in addition to asphyxia, of course, Can you next? Yeah. This shows that hypoglycemia, in addition to asphyxia, the animals would die very quickly. If you have glucose added, they live longer. So it's very clear the combination hypoglycemia and hypoxia is the worst. At least keep the glucose levels normal or maybe even high. Next slide. This slide clearly shows one message. Hypothermia is wonderful if your brain is intact. Sunshine, warmth, Greek sun is wonderful, but is not so when you have undergone deprivation of oxygen during delivery. Next slide. In an animal experiment, it was clearly shown when rats were subjected to 20 minutes severe ischemic conditions at normothermia, 37 degrees, or at hypothermia, only 2 degrees more. The survival was 100% in normothermia and only 17 in hypothermia, 2 degrees warmer. Spontaneous respiration came back after half to 3/4 of an hour, took 1.5 to 2 hours in the hypothermia group. Movements came back within 3 hours, did not come back in the hypothermia group. Seizures were only observed in the hypothermia group. So this is an example from an animal experiment that any increase in brain temperature is very bad if you had experienced hypoxic ischemic insult. Next slide. I will now discuss the clinical effects of hypothermia. Next. First of all, when you subject babies to hypothermia, and in this case the temperature was only 34.5, you can see that the heart rate drops from about 140 to about 120. The message of this graph is also when you stop hypothermia, it immediately returns to control values which were there before or a control group would have. So this is important. The moment you stop hypothermia, the heart rate is back to control. Next slide. Similarly, the rate of breathing, the spontaneous rate of breathing, drops with hypothermia to a lower level, but again, when you stop cooling, it immediately returns to control level. Next. It is important to realize when you start to warm up the baby, which is indicated here by looking at the temperature of the skin between the cooling mattress and the body, when the temperature rises in the rectum and of course also in the outer shell of the baby, the blood pressure will drop. You can see the drop of mean diastolic and systolic blood pressure. So this is the time when you would monitor blood pressure very, very closely during the warm-up phase. Next. I'm now listing here the side effects of hypothermia. It reduces the heart rate. It induces systemic hypotension. Some babies may have lower cardiac output and lower blood pressure. It may induce pulmonary hypertension, particularly also during the warm-up phase. It reduces the breathing rate, but it is not necessary to keep a baby on the respirator while you cool the baby. Many babies have been extubated or not been intubated during hypothermia. It does not cause apneas. It does reduce the urine output. It alters coagulation and acid-base status, as it would be also when you do it in a laboratory at different temperature levels, you get different values. It definitely may increase the rate of hypoglycemia and at times also hyperglycemia because of stress, which is associated with hypothermia. It has been shown that the cortisol levels all go up. Hypothermia causes a stress reaction. It causes hormonal changes analog to stress. That's why in the neural network trial we gave analgesics to suppress the stress. Next slide. Here are the lists of all the symptoms and signs which were followed in the study, and comparing the hypothermia to the normothermia group, you can see that all things like metabolic acidosis, major venous thrombosis, overt bleeding, coagulopathy, thrombopathy, hemoconcentration, systemic infection, cardiac arrhythmias, hypoglycemia, hypocalcemia, hyponatremia, elevated liver enzymes, they were all not different between the hypothermia and the normothermia group. However, in two variables, the clinical seizures, the hypothermia group had only half the rate of seizures compared to those not cooled. About 50 compared to about 27% in the hypothermia group, and also the renal function in the normothermia group was abnormal in 40 and only 26% in the hypothermia group. This indicates hypothermia has also positive effects in terms of having less clinical seizures in those who are cooled, and also having less renal failure in those who are cooled. We have not yet enough data. Probably we can also show that liver function is less affected in those who are cooled, and myocard has already been shown to be less affected if cooled, if properly investigated. Next slide. Now, I want to take away the fear and the anxiety which you might have when you start to cool a baby. For that reason, I have now produced a series of slides which are the 4 Ds: danger, disorders, difficulties, and decision making. The 4 Ds. Let us start with dangers. What are the dangers of inducing hypothermia in these babies who have hypoxic ischemic encephalopathy? First of all, the heart rate decreases, and the danger arises if the heart rate decreases not in relation to the body temperature. As long as the heart rate decreases in a similar fashion as the body temperature decreases, it's a physiological response, is no danger. Of course, if it would decrease out of proportion, then it would be necessary to investigate the matter. You would investigate if a heart rate drops all of a sudden and completely unexpected, and if it drops to less than 60 beats per minute. What would be the intervention? You would increase the body temperature to higher levels, and if it would not respond in terms heart rate going up, you would stop and go to normal temperature, and you would investigate. You would call the cardiologist or investigate arrhythmias and dysrhythmias. However, I emphasize again, as long as the heart rate falls in relation, in proportion to the drop in body temperature, is no danger. The only real danger arises when it drops all of a sudden, unexpected, and maybe to very, very low levels, like less than 60 beats per minute. Next slide. Another danger which was always pendent in hypothermia was that it would cause severe bleeding and irreversible damage to the brain by severe bleeding. So, if you have severe coagulation disorders before you start induced hypothermia, you would first immediately assess the coagulation status, and you would correct the coagulation status before and then start hypothermia. If severe massive bleeding occurs during hypothermia, you may correct, or you should correct, the coagulation status, and if you think it's not successful and it's life-threatening, you would also stop hypothermia, but otherwise not. Next. What is another danger of hypothermia? That you may erroneously make the decision to withdraw intensive care because you think there is no improvement in the neurological status, and you have overestimated the bad prognosis for neurological outcome. For that reason, this actually applies also to those who are not cooled, but in particular you would be careful not to make an erroneous decision to withdraw therapy because of believing falsely that the baby is in a very bad neurological status and has poor prognosis. You would always rule out overdosage of any drugs, anesthetics, narcotics and sedatives, because they would affect your AEG and your neurological assessment and Thompson score, and you would always make sure that you have no technical error in recording your AEG or EEG. Next. The dangers, that means dangers which are there, maybe not so immediate obvious, are that you erroneously overwarm the baby. I will show you, or have shown before, any increase in temperature is very bad for the brain. So you would continuously and closely monitor the body temperature. You use the hypothermia blanket or acetaminophen or swaddling or anything to bring down the temperature in case the baby appears to have high body temperature fever, to avoid the risk of abnormal outcome. Next. You may find low cardiac output as a disorder and a difficulty to treat. You would always treat like you would do anyway with catecholamines and volume. When the blood pressure falls and cardiac output is low during warming up, you would just slow down the warming up. Not necessary to start catecholamines or adding volume, because it's probably, very probably due to the vasculature now distending. Low urine output looks to some doctors as a danger, because if no urine comes, you would have to finally start peritoneal dialysis. The main advice here is you wait and would treat accordingly. That means you would not add additional fluid. You would just be waiting and conservative go about. Pulmonary hypertension may occur during warming up, and you would treat accordingly with nitric oxide if available. Next slide. Now, certain decisions are difficult and have to be taken into account early enough. For example, please do not delay the decision to withdraw intensive care too much, because as the time goes on, the brainstem functions recover and the baby will survive even if you withdraw all the support. And then you have the problem that you have even worsened the condition because you didn't do anything, and still the baby does not die. So the remedy is daily evaluation of the patient's status and daily consultation with the parents in terms of continuing treatment or withdrawal. And of course, there is always an uncertainty about the decision to cool. For example, should you start cooling a so-called mild encephalopathy, All studies were usually done with moderate and severe encephalopathy. Gestational age, it's said it should be older than 36 weeks. But what if your baby is 35 weeks and underwent perinatal asphyxia? Would you include it? And my message to you is that you would always prioritize the brain protection. You would always give preference to cooling than to non-cooling if you are in doubt, and induce hypothermia. Next slide. We are coming now to other practical aspects of brain cooling, namely controlling the brain temperature and its dynamic aspects. Cooling the baby is characterized by very slow changes because there is a lot of inertia in body heat, either to cool it or to warm it. It is like steering a large oil tanker of Onassis into a small harbor of Chalkidike, whatever. This is the one problem of hypothermia. It's not easy to control. It's not easy to steer. Next slide. You can see when we start to cool the baby with a fluid, perfusion fluid of a mattress at 10 centigrade, the skin temperature, which we usually measure between the mattress and the skin of the baby, falls. The heart rate falls, the rectal temperature falls, and you can see heart rate falls absolutely parallel to the rectal temperature. Then, when we come close to the range we want the baby to be, we stop a little bit earlier with this low temperature and go to a temperature nearby the one we want to have. We go to a fluid which is now 32 centigrade, and you can see it levels off slowly, and somehow we overshoot in this case with rectal temperature. So you have to learn about the dynamics. Next slide. For that reason, we always measure skin temperature, which is more sensitive to the temperature changes in the mattress and in the cooling fluid. So you can see the skin temperature already falls here rapidly, while the rectal temperature only starts to react about a few minutes later, 5 to 10 minutes later. And the same is true for changing the temperature of the perfusion fluid. It goes up very quickly, but rectal temperature only with a delay of about 10 minutes, 15 minutes. So the skin temperature measurements between the cooling device and the body helps you to see the trend much faster, which helps you to decide how long you would go with this temperature or when you would stop. Next slide. A very beautiful graph is shown here where you can see the rectal temperature in blue here. It falls actually to very low levels. When we look at the temperature of the fluid in the cooling device, it was set to 10 degrees, but the real temperature of the fluid in the cooling device in the mattress was 25 at the beginning at room temperature, and it takes quite a time, about 20 minutes, till the temperature of the machine reaches the one you have set. Then, when the rectal temperature was falling and falling, the doctor changed the temperature to a higher value. The fluid temperature was set to 31. You can see it takes now not much time till the fluid reaches that temperature. In other words, warming up goes always much faster than cooling down. But you can see the temperature takes quite a long time till it finally comes up. So this is an important message for all those who cool. It's a very specific dynamic to lower and to raise again the body temperature. Next slide. These are two further examples. When we were cooling babies in Shanghai with the Chinese device, you can see the temperature of the device was raised from 15 to 35, and even higher, but the rectal temperature was still falling, because till all the fluid is warm, it takes some time. And similar, that's the German machine and that's the Chinese machine, the same thing was shown here. As you raise the temperature, the rectal temperature still falls, it takes time till it finally goes up. Next slide. However, when we asked our nurses to regulate the temperature of the fluid in the mattress for cooling, and we examined 6 babies, you can see the nurses managed very well for 72 hours to keep the rectal temperature between 33 and 34, with some variation in between, and only few babies either below or above. And this is the warming up phase. The message of this picture is nurses with simple instructions can handle temperature control of the baby fairly well. So there's no excuse not to apply hypothermia to babies who have hypoxic ischemic encephalopathy. Next slide. We always talk about cooling babies, but some babies are so severely asphyxiated, suffering from very severe hypoxic ischemic encephalopathy, that they actually need warming. You can see the mattress fluid temperature is 36, while the rectal temperature is 33 and does not come up. It needs some warming to keep it at 33 to 34. Only later the temperature of the cooling mattress is below rectal temperature. That means only later you actually start to cool the baby. And this is the warming up phase. Next. Here is a classical example which makes this very clear. This baby has a rectal temperature around 33 to 34, needs some warming by the mattress, which is at 34.5, but later it's about the same temperature. But as the baby obviously now recovers, the mattress temperature fluid to cool has to be lowered to counteract the metabolic heat produced now by the recovered brain. That's the concept which is shown here, which I pursue. Next slide. So warming up is always very slow. It's always less than 0.5 centigrade per hour. That means when you go from 33 to 37, 4 hours, it would definitely need, it's 40 degrees, right? And only less than half a degree would need 8 hours. So this is important. Be very slow in warming up. Next slide. Thank you very much for your attention. We stop here so that we can discuss all important aspects of hypoxic ischemic encephalopathy being treated. Gentlemen, I'm continuing with the lecture on practical aspects for inducing hypothermia, and now I will discuss the requirements that you introduce hypothermia into your neonatal intensive care unit. Next. You need a certain amount of hardware which is listed here. Basically, you need neonatal intensive care facilities for resuscitation, ventilation, oxygen, suctioning, etc., monitoring, and particularly it would be very important to get or to have an AEG. If you don't have, you still can use conventional EEG, but you must get the people to do it as soon as possible. You must be able to measure temperature. A normal thermometer is possible. You can do it with a normal thermometer. Better a rectal temperature probe which allows you to continuously measure the rectal temperature. Optimal is the esophageal temperature because it's very close to blood temperature, and as I will propose to you, nasopharyngeal temperature at a certain part which is in the center of the head. Axillary temperature is not adequate because it would be influenced by the cooling device and cannot be used. What do you need? You need some equipment for cooling, for whole body cooling, cool packs, a fan, a cooling mattress, or a spacesuit for cooling. For head to body cooling, and please note, it's not brain cooling, selective head cooling, it's head to body cooling because it's always associated with some sort of systemic hypothermia as well. You can use a cool cap or the spacesuit, I will show. Next slide. First of all, you have an array of electrophysiological equipment in terms of EEG and AEG. You must decide what you are aiming at. You can use the conventional AEG, but it's not always available and difficult to interpret. There is a brain cerebral function monitor which has cerebral spectral analysis. It can also show you the side differences. Then the AMS is a very simple device which has the same features. Electromed was the old firm which was selling the cerebral function monitor. Olympic Medical and Viasys are selling similar devices as Brains. Brains, Olympic Medical, and Viasys are now devices on the market. And they have different features. It does not really matter which one you buy. I believe it depends more on your research interest. Otherwise, simple devices were the Electromed, the old one still very good, or a very simple device, the AMS cerebral function monitor. Next slide. That's the AMS. It's a small device. It gives you side differences. It has also tele transmission of the signal. Next slide. Then you need some software. You must train the nurses to some extent and also the doctors. The nurses' training would consist mainly that you give them the general rules. First of all, do not cover the infant with a blanket. The nurses comes by and says, poor child is so cold, but we have such a beautiful blanket, and puts it on. The doctor does not understand why the temperature does not fall. Or a nurse switches on the warmer mattress underneath. The doctor wonders why the temperature doesn't go down, or even has slightly added a heating device on the top. So this is very important to explain to the nurses that hypothermia is a very important treatment, and sort of personal comfort in terms of the nurses' thinking has no place. Then you must give them regulations and rules for regulating the body temperature, which are available from the European Trial Network Protocol. Then you must, of course, have some special monitoring and recording. You would record rectal or esophageal temperature every hour. You would measure the skin temperature between the mattress and the body. It's not absolutely necessary, but helpful to see the dynamic changes earlier. You would document the perfusion fluid temperature, the blood pressure, glucose, and urine output. The doctor's training would mainly consist, they must have some intensive care training, they must know the Thompson score, and should be able to apply the AEG and read the AEG and know how to treat pulmonary hypertension. So I would say you would have to have some experience of cooling, either having participated somewhere in the cooling process, or you have at least access to experts, either by telephone or by Skype. You can also send an AEG, scan it in, or fax it, and someone else can interpret it. And we will set up a European call center where always someone is available for answering questions. Next slide. I also want to point out, which you might not have thought of, that the brain temperature is very dependent on the brain perfusion. In this graph here, I show three types of newborns. Normal ones with a very abnormal hemodynamics, having hypoplastic left heart syndrome, and those with cerebral injury. It's very obvious in these babies with abnormal hemodynamics. Can you see the blood pressure is very low, 30-25? The brain temperature is 1.5 degrees higher than those of normal cardiovascular conditions. Because heat can be produced, because oxygen is still brought into the brain, is extracted, produces metabolic heat, but perfusion is so low that the heat, the waste product, cannot be carried out. So the brain heats up. The same happens when the umbilical cord is clamped. There's still some oxygen in the brain, metabolic heat is produced but not transported out. And you can also see brains which are damaged have a lower brain temperature. So this is maybe important to realize. Babies in severe abnormal cardiovascular status, hemodynamics being very bad, will per se have a higher brain temperature. Next. Now we come to measure brain temperature. My colleagues, good friends, have claimed that they are selectively cooling the head in human newborns, and they even published this nasopharyngeal temperature being about 2 degrees or 1.5 degrees below rectal temperature. But they made a mistake. They did not measure nasopharyngeal temperature more centrally, they measured it very peripherally. And so it looked lower than the body temperature. Next slide shows you when we repeated this kind of procedure, pushing a thermistor probe from the alenase in steps 2, 4, 6, 8, 10 centimeters into the nasopharynx and measuring the temperature once in a group of babies lying in a cot in a cold environment, and in another group lying in an incubator in a warm environment, you can see the following. Those babies lying in the cot, when you measure in these healthy babies not being cooled, the nasopharyngeal temperature is 35, 2 centimeters from the alenase. It's still only 36, 4 centimeters in the nose. And only when you measure it in the center of the brain, it comes very close to rectal or esophageal temperature. Our colleague Gunn in Australia measured it 4 centimeters in the nasopharyngeal passage, so they had a lower nasopharyngeal temperature and those babies cooled. But it's rather an artifact. When the babies are in a warm environment, then even at 2 or 4 centimeters temperature is already much higher. Logically, because it's warmer, 2 to 4 centimeters in the nasopharyngeal passage. Clear? The best way to measure a surrogate of brain temperature is to push the thermistor probe from the alenase the same distance from the alenase to the meatus of the ear canal, the tragus here. If you measure this distance and you push the thermistor into that, then you will end up in the middle of the head, and this we have proven in animal experiments in piglets to be the best surrogate of a brain temperature you can get. So the distance alenase to the meatus tragus, the distance, push it in, and then you are about in the center of the head, close to the brain basis. That's the best you can get. Next slide. Now, many people ask, how should we cool? What's the advantage of this and that device? That's what I'm discussing now. heat loss to environment is one way to cool the baby. Not adding any heat per se will the baby cool down to a certain level. Ice packs in the fridge are very available, everywhere available, easy available. A mattress with a perfusion fluid which is regulated to a certain temperature, a cool cap and a spacesuit. Next slide. First of all, the two principles of cooling, one is from the head with a cool cap. You will have a very cold cortex and then maybe somewhat lower basal ganglia, but they will have probably the temperature of the body temperature, which will be lower because the cold blood will go to the body. So cooling from the head is always also a systemic cooling to some extent. We don't know what temperature is reached in the core of the brain or basal ganglia. Most probably it's close to the body temperature. However, the cortex will be very cold. In total body cooling, you will also lose heat to the environment as a main source of heat loss. The mattress is only there to fine-tune the temperature, because you cannot change the room temperature as quickly, so you need some device, a blanket, to fine-tune the body temperature. The occiput, which is lying on the mattress, and the back will have a lower temperature than the other parts of the body which is away from the cooling mattress. But in principle, the cool cap trial was using the cool cap and regulated the body temperature with a heater. This systemic body cooling loses the heat to the environment and regulates the temperature with a cooling mattress. Next slide. You will all have to go back to physics, not to metaphysics, but to physics of heat transfer. And here are the physical principles of heat transfer. The heat which is taken out from a body will depend on the area which is in contact with the cooling device, will depend on the insulation between the skin and the cooling device, and the temperature difference between the body temperature and the cooling device temperature. The larger the difference, the more you can extract. The more surface you cover, the more you can extract. And the less insulation is between, the more you can extract. You would have to consider, we have discussed it already, a temperature profile which will be different according to the radius. Lower in the shell if you cool with a cap. And then you must consider that there is a dynamics. The machine must first cool the fluid, then pump the fluid through the mattress. Then the fluid must reach the baby's surface and transmit the cold. So you have quite a dynamic. That's what I have already shown. And then, of course, there will be always some parts of the body which are exposed to the environment where you will lose additional heat. Next slide. I show you now, because this is important that you can start cooling tomorrow, the method from the ice trial. You would have to cool the baby also like in the European trial, 33 to 34 for 72 hours. You would turn off radiant heater. You would actively cool with cold gel packs at 4 centigrade. That means what is in the fridge, or maybe you have to put it in the freezer. And then you would place these packets around those parts of the body which are the hottest. That means the trunk or the head. Put the head on the cool pack or put the cool pack on the head. Put the baby on the cool pack or put cool pack over the trunk. Because these are the places where the temperature is highest, where you extract most heat. No use to put them on feet or hands. Next slide. You can see they managed to keep the rectal temperature at a low temperature. This is the standard deviation. and they did this for 72 hours and then warmed up by not adding any cold. Next slide. They would also show that the mortality is lower. The data are not yet available, but the outcome of the ice trial will be similar to the one of us or Shankaran or Toby. I just wanted to show you that nobody has an excuse that he doesn't know how to cool. The ice trial has shown to be effective, and you can do it tomorrow. Next slide. The European trial was using a mattress, which is shown here. The baby is lying on the mattress. The mattress is the one which fine-tunes the temperature. The baby is losing heat. The head is accessible, and the baby always is cooled. This is important because you don't want the baby to warm up because you take off the cap. Next slide. This is the cool cap machine, which is large, bulky, and uses a cap. Next. You can see the cap again has the same principle, a water-perfused cap, then a cap which retains it on the head, and then an insulation against the environment. Because if it's very warm in the room, all cooling devices will warm up faster than if it's not so cold, if it's not so warm. That's why you would also insulate your device against the environment, as shown here, insulating out the cap. Next, I want to tell you that I'm the inventor of the spacesuit. That's why I have to declare I have an interest in this spacesuit, commercial interest. So anything I say has to be taken in this respect. Next slide. The spacesuit for newborns has the idea that the head is covered with a cap and you have a jacket around the trunk. You can regulate the temperatures of the cap extra from the one in the trunk. Next. This is the suit the baby is put into. It's a very thin material, has no insulating quality, but when the baby is in the suit, it's sort of protected against all environmental noxe and dirt and infection. Next. This is a cooling device, also a water-perfused cap and a water-perfused jacket. Next. Then this is the outer insulation to protect the spacesuit from warming up in warm environment. Next. So this is now real. Baby is enclosed in this very thin suit with a cap. Next. Here the cool cap is put on. Next. The jacket is put on. Next. And the baby is insulated against warmth from outside. Next. Well, that's the idea of a spacesuit. We come to the next. A summary of all the devices in terms of what you can do with it. Whole body cooling, cooling from the head, also taking into account that you would like to cool the baby during transport, taking into account the cooling power, because that has to do with the time you need to cool down the baby to the temperature you want it. And then, of course, the time delay and access to the head and price. All the price data here are not reliable. Please forget about those. There are cool packs which are very cheap. You can use them tomorrow. Fan is not very good, has been used. Mattress has been used in most of the trials. The spacesuit is not yet available, is more a concept than a reality. The cool cap is available, is very bulky, you cannot transport with it. And the problem is, once you take the cap off, the baby has no source of cold anymore. It would warm up. There are other firms, Critical, Cincinnati Sub-Zero, and the Chinese Full Ying, which is just a refrigerator where they took off the top and used just the cooling aggregate. It's very cheap, 5,000 euros, incredible powerful, a Chinese concept. Next slide. here is a short analysis about the amount of heat you can lose from the newborn depending what you do. It's a model calculation, it's a theoretical calculation on a 3 kilo baby which should be made 3 centigrades cooler, and you should extract about 7,560 small calories, or 7.5 kilocalories, in an environment which is 28 degrees and one which is 34 degrees. And I also calculate the duration, how long it would take till the baby reaches the temperature between 33 and 34. Well, very short. If you just go by cooling with the environment, that means no heat is added, the environment is 28, you can extract 135 calories, and it will take 56 minutes to reach the cooling temperature in a 28 centigrade environment. If it's very warm, it will take more than an hour, nearly 2 hours. When you cool with a cool cap or a mattress from the back, then you can extract more, but not that much more, because still a lot of heat is lost to the environment. But it will be somewhat faster, and in a warm environment it will be 1 hour and 20 minutes. If you, of course, wrap the whole baby, head and trunk, and cool, then it takes only 42 minutes to cool the baby down in a cold environment and 55 minutes in a warm environment. Very clear physics. The more area you cover with a more cooling fluid in contact with the body, the faster and the more you can extract calories. Next. This is just a graphical representation. I think it's something you can look at it in quietness. It gives you the calories which you can extract in relation to the other devices. Next. And this is again a summarization of the time it needs. In 28 and 34 centigrade environment, when you use only environment, that means no heating device, just an environment which has 28 or 34 centigrade. It takes, as you can see in warm environment, 106 minutes, otherwise less than an hour if it's 28. Of course, the more you cover, the faster it goes, but still with only the environment, you take a long time, with not having any additional device to cool. Spacesuit, which covers most of it, goes faster. Next. Finally, we all will have to learn the criteria according to which you choose a device. Like with respirators, we have certain criteria, and here I have compiled the criteria which you should apply before you choose something. First, you would ask, what is the power of heat transfer? How much heat can you extract from the baby in a unit of time? It will depend also how much volume is used in the machine and which temperature gradients the machine can cause. You would ask, what is the response time of the machine to cool down, for example, a fluid from 37 to 34 degrees? Because there is a delay by the machine to cool the fluid. Also, you would ask, how much time does it take to warm up from 31 to 34? Is heating fast enough? Like the Chinese machine has no heating device. Then you would ask about the volume. How much volume has to be cooled or warmed? Because that determines the response time. Is it servo controlled or not? And then from the jacket or surface area, how much area is in touch with the skin of the baby? What's the insulation between body and the jacket? What is the overall response time of the baby to cool it down by 1 degree or to warm it up by 1 degree? And is there also insulation between jacket and environment? So these are criteria which I believe will be the standard from now onwards to judge the devices. Next. This graph shows the entry criteria which you can also download from internet, and I'm not going to go into details. They're all very similar, whether from the CoolCap or Toby trial, the NIH study, or the European trial. Next slide. We have already said you need some inclusion criteria, and the inclusion criteria are always stepwise. You would first assess the asphyxia, and then you would assess the encephalopathy and come to the conclusion which degree of severity the baby has in terms. Next. Next. And we have already discussed that there will be definitely some indications for applying hypothermia. All hypoxic ischemic encephalopathies following perinatal asphyxia, but also global asphyxia as it occurs with cardiac arrest in a newborn in the neonatal intensive care. Why should it not be subjected to hypothermia treatment if it has exactly the same pathology as a baby during the delivery? Facultative neonatal stroke. Next. I have already mentioned that hypothermia is now a standard treatment. It was already published in the ILCO recommendations. Here is a number of people who were involved in this statement, and it's very clear that it is no longer an experimental treatment. Next. That is the ILCO recommendation 2007 as a citation you may need. Next. Thank you very much for listening to the second part. We have more time for questions. I think the food is waiting for my stomach.